Well, good morning. No, it's afternoon already. This talk will be in English. I hope that will not be a problem for all of you guys, because I think that you can manage that. Today I will talk about value-based healthcare, as already mentioned by Nikos. And first of all, thank you for the invitation, of course. Well, let me first introduce myself and my company. So my name is Vincent Wiersma. I'm a consultant at the Decision Group, and I'm a consultant which spends 100% of his time on value-based healthcare and implementation of this concept. And for all of you guys, a little bit of my background is I did a bachelor in biomedical sciences at the University of Amsterdam in Holland. And then I did a master in science and business management to combine the medical approach with basically the economic approach in healthcare. And to that extent, I started at the Decision Group, which is a consulting firm and gives advice to care providing organizations and a lot of stakeholders in healthcare. And I started working with the concept of value-based healthcare, and it really grabbed me immediately. So I started reading a lot about it and watching a lot of movies about value-based healthcare and read a lot of cases where value-based healthcare is implemented. And what I saw, that this was a concept that is able to truly and fundamentally change the way we deliver healthcare. And that struck me. And I thought, well, I thought we delivered great healthcare, so why change it? Well, it actually, and I will be a bit hard on that, well, there is a lot to improve in healthcare. So basically, we did over 100 unique projects in the Netherlands based on value-based healthcare in several areas. And I've provided, together with the professor Fred van Eenenaam of the Decision Group, we provided education mostly in the Netherlands, but also in Europe. So we educated more than 20,000 people already. We are developer of the value of medical products methodology, which I won't talk about today, but to show the value of a medical product in a value-based healthcare way. And last but not least, we have an annual prize, which is called the Value-Based Healthcare Prize, which is a European incentive to award the care-providing organizations and collaborations that really fundamentally think different about our healthcare system in a value-based healthcare way, and to put them on a stage and shine the light on them and really motivate them to move forward in that sense. So the previous talk also mentioned it already. We have a lot of rising healthcare costs, and not everyone is focusing on value, in my opinion. So there are a few reasons for that, and only naming three. There is a lot of medical innovation going on in Europe and in the rest of the world, and we have troubles of an aging population, and that's also the case in Greece, I guess. And we have to provide more chronic care because the life expectancy increases, and there are multiple comorbidities coming up in the later stage of each life. So I don't want to focus on the reasons today, but more on the solution, how to fix healthcare in this fundamentally different way. And that's why I'm going to talk about value-based healthcare. Probably you all know the concept or heard of it. And if you don't worry, I will explain it to you. It's a concept which is originated by Professor Porter at Harvard in the US, of course. And he really states that the root cause in every healthcare delivery system at this moment is basically that we have trouble to keep the focus in healthcare on patient value, to create patient value. And Well, this is a great example which shows exactly what he means, I guess, is that we are reimbursing healthcare, for instance, in a fee-for-service way and not in a fee-for-value way. And that is, if you think about healthcare, really weird. That we reimburse a doctor or a hospital for a service provided rather than the value delivered. The consequence of that is that not all focus is on care delivery and achieving improved care delivery, but rather unmanaged, unexplained, and some explained variation in healthcare delivery, which is costly, it's expensive, and it doesn't provide any value for patients. So who is getting paid for value? That should be the real question. And in most European countries, it's the case that the one who's paying for healthcare is in charge. And that is really weird because the whole healthcare system should be organized around the patient, because that are the patients that we treat every day. So we have to change the dominant power towards the patient. They should be at the center of attention. And of course, this is a difficult situation with all the stakeholders we have in healthcare. So how can we achieve this? How can we really achieve value in healthcare? And this is something we have in the Netherlands, so maybe it's not in Greece as well, but we see a shift in the power of a patient as well. We see, I heard the term Google, but my Greece is not really good, so I did not know what the professor said. But I always say Google is my best friend. Patients can go to Google and see what they have, which condition they have, and what needs to be done to be treated. So they are getting another position. They want to be as healthy as possible, and they think along, think ahead, and want to make decisions in a shared way with the doctors. And then the question arises, what is the value now for the patient or the consumer, as we see in more industrialized sectors? And that's where value-based healthcare comes into place. And it really fundamentally lets you think differently about the healthcare sector, because it's all focused around the patient. And in this book, Redefining Healthcare, is the basis of value-based healthcare provided by Professor Porter in 2006, so 10 years ago now. And we already see some examples in the world in which value-based healthcare is implemented. And the second half of my presentation will focus on those examples to show you what it can really achieve by focusing on patient value. But first of all, let me first introduce the concept itself, because we need to understand how to fundamentally think differently before going into the examples and explain those. So the first thing we need to think about is, if we talk about patient value and creation of patient value, which should be the ultimate goal of every healthcare system, then we have to think, where is value in healthcare created? And the value in healthcare is created by the relation between the physician or the medical doctor and his entire team and the patient and his or her family. That is where the transaction of value takes place in healthcare. So that should be the focus of our healthcare system. And Porter defined value in the following way. He says, well, patient value is actually the outcomes achieved, the health outcomes achieved per dollar spent, or here in euros spent, of course. And that mainly focuses on doing the right things in an effective way, which delivers value and health outcomes, and on the other hand, make it efficient and standardize care to reduce cost, of course. And this should be done as a bottom-up approach if we look at value-based healthcare. If you really want to make this shift happen, you have to start where value is created, at the doctors and the patient, and that interaction. That's the only way we can change this culture, by changing them. So it has to be a patient-centered way, and on the other hand, a doctor-driven way. they are the ones who makes the shift happen. And then, how can we do this? Well, patient value, outcomes, costs, it's still maybe a bit abstract. So I'm going to make it a little bit more specific here. And that is what Porter says: if we want to focus on the health outcomes on patients, we need to measure outcomes. And right now, in most healthcare delivery systems, we measure process indicators. So we measure what the clinical chemistry department measures. So a value of, well, of your blood. But that doesn't really create the outcome of the patient. I mean, the patient outcome should be measured over a full cycle of care. And traditional hospitals are divided in several departments. And that is strange for value delivery, because we have a hospital structure with several departments like oncology, radiology, and cardiology. But a patient doesn't come to the care provider with, I have radiology. He doesn't have that. He has a medical condition. So he comes in with, for instance, and he doesn't know that yet, but probably prostate cancer, for instance. That is his medical condition. So we should organize our care around the patient's medical condition over the full cycle of care. And what does over the full cycle of care means then? Well, that is actually that there are multidisciplinaries involved in caring for the patient. So it's not only a procedure performed by a surgeon. No, there is also a physiotherapist for the follow-up. And there is also a GP who actually states what the patient has and really provides him the right care, or sends him to the right surgeon. That's what needs to be done. So that's what Porter says as well, is he says if we want to focus on value, on patient value, we need to deliver care for a patient with his or her medical condition over the full cycle of care, from the moment he first sees his general practitioner until the moment he leaves the hospital or leaves follow-up. And then outcomes should be measured over that full cycle of care. And to take it a step further, if you want to really implement value-based healthcare, then there are basically 4 core elements that you should take into account. And that is first, by measuring the right outcomes, as I just mentioned, over a full cycle of care. Second of all, you have to measure the real costs. So not the reimbursement, but the real costs for delivering those health outcomes. And then, third of all, you need to organize your care as a care provider around the patient's needs and the patient's medical condition. And then last but not least is it's all about the patient and the family and the doctor and his team. So try to use that to learn and collaborate with other stakeholders in healthcare to create a learning cycle to increase those outcomes. And the last thing on the concept itself is that if we focus on the right outcomes, and we do that in a good way, costs will go down. And that seems weird at first sight, but all the cases that we see right now focusing on outcomes reduces costs. And that's maybe strange, but on the other hand, if you focus on the right outcomes, you can take action, you can manage those outcomes, and you can manage the entire care process of a patient to increase efficiencies and to reduce waste in the complete cycle of care and duplicates. So that is a real, the background of value-based healthcare, how to change a healthcare delivery system towards a value-creating delivery system. So just to show you one example of what outcomes should we measure then, we see that in another example later. And Porter created the outcome hierarchy. And that basically says if we want to measure outcomes over a full cycle of care, we have to look at 6 different tiers of outcomes that we measure. And first of all, and that everyone agrees always on that, is survival. Do I survive or not? And then the second tier is basically, what is my degree of recovery? And then the third one, and I think that's also a very important one, what's the time of recovery to return to my normal activities? That are outcomes that matter to patients. And then fourth, the disutility of treatment. So, at what expenses in health conditions? What is the disutility of care? So, what are my complications? Do I get depression or something? And then fifth and sixth, I will take those together. It's more on the sustainability of the care provided and the long-term consequences of your outcomes. So that is more into the patient quality of life. So that aspect is more represented in the lower tiers. And what you can see is a nice division that more on the upper level of the outcome hierarchy, there are more hard medical outcomes that you can measure. And on the bottom, there are more quality of life aspects to measure for a patient. And one important thing, if we measure outcomes, and if we measure the right outcomes, and I just want to mention that briefly. If we want to do that, the first thing you will notice if you say, well, my outcomes are better for patients than the other hospital. The first thing a doctor will say, yeah, I can imagine, you have the more easy patients. That's the first thing he would say. And to manage that problem, you have to correct those outcomes for patient initial conditions, as Porter says, and that are basically a case mix variables. So, for instance, I put a few on there, and I think one in Greece, which is really relevant, is smoking, diabetes. It's in almost every country there are the same parameters to correct for. And you can imagine that because if a patient comes into the cycle of care for the first time, he's 80, he has diabetes, he smokes, he's not healthy, his physical condition is weak, then his outcome will be probably a lot lower than a super healthy patient. So just correct for those initial conditions, and then you have the right outcomes to measure. One quick example. The first example of outcome measurements is by UCLA Medical Center in the United States. And this is just a graph to show you how the outcomes were for kidney transplantation in 1987. So one of the first years that they were actually performed. And then they started measuring just simple one-year graft survival, but only for patients with a transplantation. So chronic kidney disease with a kidney transplantation. So that's the medical condition, not based on a department or a hospital. That's the first time they started it. And now, this is what happened. And I think this proves actually already why outcome measurements can improve care and quality of care. They moved up tremendously over 20 years. So that's what it can do by measuring the right outcomes. And you heard it yesterday probably as well by Jason from ICHOM. Outcomes are really important to measure. So I want to focus now the last 10, 15 minutes on three major examples from Europe implementing value-based healthcare. Two of them are in Germany and one is in the Netherlands because I'm from the Netherlands, so why not take an example from the Netherlands? And what I think is really cool about these examples is that the first one, the Martini Clinic, focuses really on the upper level of the equation, namely the health outcomes. And then the second one, the Schön Klinik of Germany, focuses more on the cost side of the equation. And then the third one is more of a already a step ahead and is measuring outcomes, but is already learning from those outcomes and creating a learning cycle. So I think these three examples will show what the concept of value-based healthcare can do in practice. The first one is a really clear example of value-based healthcare delivery because, and this is the only slide I will show you about the Martini Clinic, but the Martini Clinic is a hospital in Hamburg, in Germany, And the physician or the surgeon on prostate cancer, the urologist, started measuring outcomes for patient after attending a session of Porter. And what he thought was, well, we have not much patients. I want to improve care delivery. Why not start by just treating patients with one medical condition, prostate cancer? And he started that. And he started a separated facility, which is called the Martini Clinic, only cares for patients with prostate cancer and organized the care around their medical needs. So they started it, and every now and then, I mean every 2 months or so, they came together, all the urologists and all the other specialists involved in care providing for prostate cancer patients. And they looked at those outcomes, and they just mentioned to each other, how can we improve those outcomes? And the leading urologist, Professor Hartwig Huland, the leading urologist at that time, said, well, I see that my outcomes are inferior to yours. Better than I do. That's what he just said in the meeting, and that's quite unique amongst physicians, as you probably know, or surgeons. But he asked the simple question, what are you doing better? And one of the surgeons reacted and said, well, I take 30 minutes more for my operation to spare some nerves. That's what I do. And then I think the greatest thing happened. Hartwig Huland said, well, if you take 30 minutes extra, I'm going to watch it. I'm going to stand next to you during surgery, and I want to see what you do other than I do. They stand together at the operation room. They performed surgery. He helped, of course. And then it worked. He saw that nerves were spared more. And that's what also can be seen in the graph. They used another technique, and outcomes improved. Just by learning from each other. And if you see the outcomes right now, I mean, first of all, these are the outcomes you have to measure. I mean, severe erectile dysfunction. I'm a man, I can say to you, it is important to measure that outcome. On the other hand, continence. That's really important for patients. And if we see the average outcome of Germany, and we see the outcome of the Martini Clinic, if I would have prostate cancer, I would certainly go there. Why? Because of the improved outcomes. One slight other remark I want to say. Everyone is saying, well, they achieve better outcomes. I see that in the US as well, but it's quite expensive, isn't it? Actually, it isn't. I spoke to the CEO of the Martini Clinic last week. He said to me, his reimbursement rates for prostate cancer patients are 5% lower than the average of Germany. So it's cheaper as well. So I think that's one of the greatest examples in Europe to see on outcome measures, how it can really improve value for patients. Oh, I see my time is limited to 6 minutes, so 7. So we'll try to speed up a little bit. Second example. Schön Klinik as well. What they did is they started a program or a pilot to really capture the costs of care delivery. Not the reimbursement, but the actual cost made by a care providing organization. And they took the value-based healthcare approach. They started with a medical condition. And I thought it was knee replacements, total knee replacements. And they captured all the activities from a moment the patient visited the first the first visit of a care provider, until the end, the follow-up, and the patient left towards home. That's what they captured, all the activities, the care delivery activities in a sequence. And what they did is they used a method, which is now, I think, the best costing method in healthcare, and that's just time-driven activity-based costing, which basically says you map your activities, what you are performing, and each resource used in that activity. and then it measures a cost capacity rate. So you measure the costs of a product or a resource, and you calculate it back to the minutes that you use it, and then you multiply those two. That's the simple version. So basically what you do is you measure cost by multiplication of the time spent on a patient, on care for a patient, and the resources used. And of course you have troubles with overhead. Well, there are reasons, or there are ways to do that. Sorry, but that is the basic methodology of time-driven activity-based costing. And what they did is they captured the total cost cycle of care. And what it actually led to is, because they mapped every activity they performed, they saw duplicates. They saw that some things were happening twice, because one doctor was performing something or requested an X-ray, for instance, and then sent him to the next doctor, and that one said, well, I'm going to do a new X-ray because I want to look to a new picture. So there were a lot of duplicates in there, and they saw that, for instance, and I think it's in the next slide. So what they saw is, first of all, in operations, they just thought that the costs were normal for an operation from beginning to end. Now they measured the cost from the first cut to the next cut of the next operation. That is the whole process and the whole activity. And what they did, and that is really great, what they can see through these process maps of the activities is how to allocate labor, and to see that the most expensive resource in healthcare is the surgeon, or the professional, the healthcare professional, the medical specialist. Those are expensive. And use those on full capacity. That is a trick you can learn from this, which is really valuable, because a lot of highly expensive surgeons are doing the wrong things, which more expensive, well, cheaper, I wouldn't say, but cheaper nurses or other professionals can do. And the results are amazing, I think. The cost dropped tremendously with $1,300, and the profit margin raised. And that leads to reinvestment in, for instance, rehabilitation. And they could provide that by an own, generating an investment cycle for themselves. Example in 2.5 minutes, I'm going to try to take it in between, is a Dutch example in cardiology. So I think Professor Vardas already knows it, which is measurably better. And what they did, well, I have to sketch a little bit of the background. Because of their low volume, 2 hospitals were excluded from performing heart surgeries because of the volume. They thought, well, that's not the great reason. We want to be excluded from heart surgery based on our outcomes. So we shall provide you the outcomes that you should measure. And they did. They started measuring outcomes, and they wanted to improve the transparency of outcome measurements in the Netherlands for cardiology, which they did. So they started the program Measurably Better, and they defined outcomes. That's the first step they did, they took. Second of all, what they did is they talked to other hospitals to measure those outcomes. Now, at this moment, I think, 19 hospitals already involved in the Made by Beter program. And what they do, and basically from all the heart centers, which are 16 heart centers, 14 already are included. And what they do is they transparently measure outcomes on a provider level, and they report it transparently in an outcome book every year. And what they are now doing and seeing is that care is improving on the one hand, but on the other hand, based on the outcome book, there are multidisciplinary meetings inside the hospital, but also between the medical specialists of hospitals to see where improvements can be made. And one major example in this field is a safety check is implemented in the Netherlands right now. And that was a basic thing that struck me, to be honest. What they saw is that one of the hospitals was performing a safety check before operation, before surgery. And they just had a checklist of 10 points, and there were basically like, did we wash our hands? And which leg to operate, or which chamber of the heart to operate in this case. Such simple things were on the list. And it was not performed in other hospitals. And we thought we had good care. That's what it improved already. So there were a lot of improvement points that were discussed in those meetings. And think again, who were attending those meetings? The physicians, the doctors, the teams, the medical teams. Because they can do it differently. They can make this change happen. It was a great learning moment for me, and to see that there is a lot of improvement still to make. Well, I think this is the other part that is really important, is that this program is a doctor-driven approach, which was really helpful in this case. And what it stimulates is inter- and intra-organizational learning. And I think that's what creates value in healthcare, by discussing and collaborating based on value. And I think value-based healthcare can be a common approach and a common goal in healthcare, but it also creates a uniform language, actually, between the stakeholders in healthcare. I think that's an important point too. So, to sum up, as I see my time is over, just a brief wrap up from the session and the things we learned from these case studies is we have to start measuring outcomes for a medical condition over a full cycle of care, and at the same time measure the cost to achieve those outcomes. Second of all, I think start with the medical team, because they can provide this shift in healthcare, but involve as much as possible. Third, organize your care around those medical conditions and the patient needs. And fourth, and I think that's the underlying focus of value-based healthcare, is to collaborate based on this common language, and to collaborate and learn from each other and learn from the best in class, and not abandon the ones that are underperforming. Just show them how it can be done better, and create an improvement culture. So last two slides and then we'll wrap up. So for years, just briefly mentioning what we see right now is happening in the healthcare landscape in Europe. We are going to move towards bundled payments. So we're going to provide the care providers with one payment to provide care over the full cycle of care for a medical condition. So you get one payment, and you have to provide all the care and the complications afterwards and everything, and that's it. That's how we stimulate value and not volume. Other one, and I think that's one important one, the 7, the cultural and transformation change leadership. So medical specialists should drive this force. And I think Greece, maybe I'm way ahead now, but after the crisis, I think you have a major opportunity to really fundamentally shift towards patient value. So I think you have a large opportunity here. The last one is more a practical approach. If you want to start such a pilot in value-based healthcare, how to start, because that's always an issue. I think the most important thing is search for the front runners at care providing organizations, so the leading medical specialists, for instance, and create a team of disciplines. 2, define outcomes and start measuring. Well, it's an open door maybe, but it's the relevant one. And I would always advise to start with outcomes and not with costs, because they will follow. And the last but not least is to create a learning culture and stimulate and organizational improvements, and avoid a judgmental culture. So that's it. And if you have any questions, please email me, no problem.